Sure.
There were a lot of Indian fellows.
I think there'll be a lot more people coming, but
It's okay. I don't get easily offended.
They do keep Gerberling in until about 12:30 at least.
let me introduce our speaker today, folks. We've got Steve Haffner today, who is not only a professor of medicine in the Division of Clinical Epidemiology, speaking to us today on the metabolic syndrome, but it's really a world's authority on this syndrome, and really privileged to have him in our midst, let alone have him speak with us today. He's an old friend and getting older by the day, I guess, but not as old as I am. So, Steve, thanks.
By only 1 year, by the way.
Yeah. Thanks for coming.
So when I first came in 81, Mike had come in 80. His office was 4 doors down. Mike and somebody, probably most of you don't remember, James and I came the same year.
The person with more board examinations than any other doctor on earth.
That's right. Is he still somewhere in North Texas?
Yeah. As they say, somewhere upstate Texas.
And-
It's upstate New York.
No,
No. Anyway, what I'm going to do is talk a little bit about the metabolic syndrome. When do people turn into pumpkins?
Well,
1 or
there's
115?
not, pretty much about 110, something like that.
Okay, so I'll keep this to about 30 minutes, maybe a little bit more.
Don't try, they just get up and leave. Okay.
That's okay. They probably leave even faster if there was food, as soon as they leave. Anyway,
Good seating over here.
we became interested in this. I was a diabetes consultant to the Onset, and it was sort of an add-on at the very end. And at the time people actually went home, we realized that we actually knew very little about this concept. The concept of metabolic syndrome is not new. It's in fact a very old syndrome. And the way it used to be described is really clustering of cardiovascular risk factors. Its initial description by a group of Italian investigators. And then Bill Cano in the Framingham study noted that it was linked to obesity, which was probably far and away the most single important observation. And then there were a group of investigators, Hannafeld in Dresden, who wrote, unfortunately for them, in German, and described really what Jerry Reven later described, but they actually got it more correctly. See, Jerry Reven is very interesting because he didn't like the idea that the concept that other people had thought about clustering associated with obesity, and Jerry, being brilliant and a little bit peculiar, decided he would prove that it occurs even in non-obese subjects in relationship to insulin resistance, which was true, but it ignored a major reason why most people are insulin resistant. So if you go into the initial description in 88, he sort of stripped away obesity from the concept of the insulin resistance. Very peculiar. And it's only over the few years afterwards, principally with work from Dupre and other groups, that people again started focusing on a central aspect of visceral fat. So I'm going to talk about just a few areas, and I'll skip over really probably half of my talk, and I'm going to concentrate on what does it mean for cardiovascular risk factor management? how great is the risk of the metabolic syndrome for heart disease? Does this mean that you should intensify therapy, say, for risk factor management? So, I mean, some other time I can talk about some of the other aspects. And I'll talk a little bit about conceptual frameworks. So let's look at an example of a metabolic syndrome, diabetes. And I'm going to come back to some actual data later. It's estimated that about 80 to 85% of all type 2 diabetic subjects have the metabolic syndrome. But most people with the metabolic syndrome do not have diabetes. And that's true really in all populations. So if we want to benchmark the issue of how high the risk is, we could start with diabetes. So this is a paper we published a couple of years ago looking at diabetes in relationship to future CHD stratified by prevalent CAD. And it's been used to justify a concept of diabetes as a CAD risk equivalent. And if you look at some of the actual numbers, you can see among non-diabetics in this particular paper, there's about a 5-fold increase in risk. Among people without a prior MI, and that's probably a little bit high. And if you look at people among a prior MI, it's about 2 to 2.5-fold higher. So the effects of diabetes on future risk of cardiovascular disease depends upon whether somebody's already had an event or not, and it's attenuated in people who have already had previous vascular disease. And that's true of all risk factors. It's not a surprise. So if we leave the observation that diabetics without a prior MI are similar to non-diabetics with an MI, there's another observation which is seen in almost all trials, which is that diabetics with an MI are at higher risk than non-diabetics with an MI. Now, if we think about risk factor managements, until recently, the concept is that all people with vascular disease have a similar degree of risk. It's interesting, and I'm going to come back to this at the very end of my talk. There was recently an NCEP white paper that suggests that some people might be categorized into a very high risk category. Those people might have an LDL goal, say, of less than 70. We'll talk a little bit about whether it's justified or not. And one of the groups, in fact, the first group they talk about are diabetics with vascular disease. So using that as a benchmark, what about people with metabolic syndrome? So one way to look at this issue is to look at this the way, cardiologists look at diabetes and CHD, which is usually backwards. So if you take people who have had an MI, we can ask how many of those people have diabetes and impaired glucose tolerance. So this is a study by Norhammar. It's from the Karolinska, very, very famous unit in Stockholm. And they looked at consecutive patients who were admitted to a coronary care unit and confirmed to have a myocardial infarction from Monday to Friday. Now, what do I mention this? Well, this is for the fellows. They're very tough work rules in Scandinavia, and you can't force research assistants or doctors to work on weekends unless they get paid supplemental salaries. It's the most important observation you're going to learn here. You should have probably gone to medical school in Sweden. You also get paid, by the way, for being on call. And the baseline salaries aren't bad either. And so anyway, what they did is they had consecutive patients admitted with a myocardial infarction. They excluded everybody who had known type 2 diabetes and then did an oral glucose tolerance test in people who were not known to be diabetic. And that data is shown in green, and 35% of them had IGT and 31% had new diabetes. So about 2/3 of individuals had some form of glucose intolerance. Now, this is something that can actually be replicated fairly easily. And as far as I know, no paper has actually been published, although some people have been working on it, looking at this issue. Now, is this just an epiphenomenon? Is this just because when people have MIs, their glucose levels rise? So to get around this issue to some degree, the investigators repeated a glucose tolerance test 3 months later, and that data was shown in yellow, and again, about 2/3 of these individuals had some form of glucose intolerance. A little more IGT, a little less diabetes, but the numbers aren't terribly different. So this represents sort of a stable, high-risk population, probably should be used more often in clinical trials. Okay, and I'm going to skip some of this. This is some data from the UKPDS using a justification on why glycemia isn't so important. Now, our group, I'm going to just sort of summarize this and not go through the studies at this point. Our group has been very interested in why glycemia during the diabetic phase is not such a strong risk factor for heart disease. And the concept that our group is sort of favored is that there's already increased risk of cardiovascular disease prior to the onset of type 2 diabetes. And I'm going to just sort of tell you about some of this data and not go through it. And why talk about this? Well, this is another model of the metabolic syndrome, and I'm going to show you this on the next slide. So I'm going to show you data from a paper we published a long time ago, when both Mike and I were not gray. It was back in 1990. At least I wasn't gray then. You know, for many years we convinced our children that people turn gray from their children, which is partially true, of course, but then they eventually figured out there was a confounding effect of age.
How do you define prediabetes?
So this is a study. This is not the ADA definition. We do longitudinal studies, so we actually know who actually will develop type 2 diabetes. So this is defined longitudinal. The ADA defines prediabetes as impaired glucose tolerance or impaired fasting glucose, which is really rubbish. It was a technique to increase their market share. You have to think of the ADA as a group much like a pharmaceutical company that wants to expand the number of people who might give them donations. So anyway, this showed the general observation. We then went on in a number of further papers to show it's mainly related to insulin resistance. I'm not going to talk about that. There's additionally some data, and this is a very important observation, that there's also increased cardiovascular disease prior to the onset of type 2 diabetes. And why is that important? Well, it's important because for many years the American Diabetes Association has talked about strategies of frequent screening for type 2 diabetes and then improved glycemic control. But if it turns out that increased cardiovascular disease occurs prior to the onset of type 2 diabetes, screening will not eliminate those cases. You'll have to intervene at an earlier stage. So this is a very important argument for prevention strategies. And the last is a little bit about inflammation, which I'm going to talk about briefly. Okay, so I'm going to talk about just one issue about prediabetes. This came out in JAMA in 1990. We looked at people who started with normal glucose tolerance. We followed them until some of them became diabetes and some remained non-diabetic. Normal was really incorrect. Some of those people had IGT. And those people who later developed diabetes had higher triglycerides, lower HDLs, higher blood pressure, slightly higher glucoses, and much, much higher insulin concentrations. So they were at increased risk of heart disease. But the relevant issue here is if you look at these disorders, triglycerides, HDLs, blood pressure, glucose, and insulin, it's exactly the components that make up the metabolic syndrome. And in fact, they were 2.5 times more likely to develop the metabolic syndrome than people who did not develop type 2 diabetes, even though both groups had normal glucose tolerance. So this is not just a glucose phenomenon. little bit about this. This is some data from the San Antonio Heart Study, and this will just give you a little bit of concept since this is actually data from this town. This looks at categorizing a non-diabetic population over a 7 to 8 year follow-up. And what we did is we divided the population of non-diabetics by a median split on something we call a Homer IR. It's a surrogate measure of insulin resistance. But for the purposes of this talk, it's fasting insulin. The correlation between Homer IR, which is fasting insulin times fasting glucose, divided by a constant, with fasting insulin is actually 0.98. It's identical in non-diabetic subjects. And the insulin cut point that would correspond to this, again, depending upon the assay, using a commonly used coded antibody, a DPC antibody, is about 14.5. And then we also divided the population by whether they had an insulin secretory defect. And I'm not suggesting anybody do that. We did an oral glucose tolerance test and measured the change in insulin from the first 30 minutes of an oral glucose load over the change in glucose. And what we found is that people who just had a secretory defect had a 3-fold increased risk. Those who were just insulin resistant had a 5-fold increased risk. And individuals who had a combined defect had a 20-fold increased risk. Now, Mexican Americans, African Americans, South Asians do not have more secretory defects. They have more insulin resistance in the general population. So there's a shift of insulin resistance. Even in high-risk populations, secretory defects are equally important, but because they're working against a greater load, they're likely to develop a relative insulin deficiency earlier, and therefore not only develop more diabetes, but as a public health issue, develop it early. Now, I realize that's not so important in geriatrics, since you're dealing with people who are really survivors in a sense. And so diabetes has its biggest impact on complications in young people, and progressively has less and less impact. So if you develop diabetes at the age of 80, frankly, I don't actually honestly know whether you should get people to less than 7, or less than 8 is adequate, even 9. One of the things that's interesting...
It's a really big debate for us.
Well, one of the things that's very interesting, if you think about this globally, risk factor management, is the NCEP has a structured approach dependent on the degree of vascular risk. The blood pressure recommendations, JNC7, moved backwards. Some of you remember JNC6 had category A, category B, category C. And category C was people with end-stage renal disease, diabetes, and MIs. When they moved to JNC7, they continued more aggressive goals for renal failure patients and for people with diabetes, but they backed off on MIs or stroke. I find that very interesting. So they are now basically saying that you treat people for common blood pressure and you don't intensify people if they're at higher risk for complications. The diabetes community has never geared their hemoglobin A1Cs to the degree of risk. And how could they do this? They can do this in one of two ways. One is they could make the intellectual leap and say that much of the macrovascular risk could be treated by risk factor management, which a lot of physicians are starting to really think about. And the microvascular risk, you need improved glycemic control. So if somebody develops type 2 diabetes at 80, how long does it take for them to develop microvascular complications? And there are, in fact, some risk models based mainly on type 1 diabetes, and they reach actually different answers. There's a paper by Trevor Orchard and Andrei Kolovsky that suggests there's a threshold. And Trevor's data in type 1s suggests that you don't develop retinopathy until you have something like 1,000 hemoglobin A1C months. What does this mean? Well, if you take 6 as normal, you have to have 1,000 months above 6 to develop retinopathy. So if you're at 7, you're probably not going to develop it. But if you're at 8, you may develop it 30 or 40 years on, and if you're at 9, you develop it sooner. So if you applied that to an 85-year-old who has an average lifespan of about 7 to 10 years, depending upon their gender, it might be safe to keep them at 9. Now, you have to remember, these aren't absolute numbers. You need confidence intervals, which haven't been supplied. Let me ask you a question. Framingham Global Risk, are there confidence intervals for that? We talk about calculating global risk. Well, not knowing is good. There are no confidence intervals. They can't be calculated in the method. It's something they never actually told people when they started to promote its use. So if you say somebody has a 15% risk of developing hard CHD events over 10 years, we don't know whether the 97%, 95% confidence interval is 13 to 17, in which case it's a very precise estimate, or 5 to 25%. Does it make a difference? Well, of course it makes a difference. Patients are risk preferers or risk averters. Somebody who is a risk preferer may look at a very wide confidence interval and say, well, maybe that's not so bad. There's a relatively good chance I won't develop it. So there's a lot about risk estimation. People write papers and they don't truly understand the implications of it. It's written by clinicians or pseudo-statisticians, people in general medicine and diabetology, who don't actually understand the implications of making recommendations. The problem, of course, is some people actually believe the recommendations. Okay, so this tells you a little bit about risk factors, and there's other data. Another way to put this into a perspective, and this again is data from the San Antonio Heart Study, is let's look at the characteristics of people who actually become diabetic before they're diabetic. Remember, this is longitudinal data. And this is a very conservative way to do it. We're looking at median splits. So 54% of the population has a combined defect of insulin resistance and decreased insulin secretion. And that's exactly what you'd predict, given that both together are a very striking risk factor. 29% have just insulin resistance. A little less than 2% have neither defect. That bothers some people, but frankly, all data has warts in the data. If the data is really perfect, you should be suspicious. And some of these people actually later gained weight, so there might be an explanation, but I don't frankly feel that in most databases you have to explain every observation. There is chance and there's unpredictability in real data as opposed to simulated data. And about 16% of subjects have principally secretory defects. So contrary to what some people say, not every person who comes in, at least at some point, is necessarily insulin resistant. 85% are, a very large proportion. Not quite everybody, and this actually may have something to do with the risk of heart disease. So let's skip over some of these things. This is just the data. This is a paper you may want to look at by Frank Hu, looking at the risk of heart disease prior to the onset of type 2 diabetes. It's from the Nurses' Health Study. It came out in Diabetes Care in 2002. I'll talk a little bit about CRP. Probably nobody measures CRP here, because by the time you get to be old enough to be considered in the geriatrics thing, you're no longer interested in premature factors related to premature CHD. They're not particularly useful. We were interested in CRP because it might be associated with the metabolic syndromes. This is some work from a study called the Insulin Resistance Atherosclerosis Study. And we were one of 4 centers here in which we did frequently sampled intravenous glucose tolerance tests. And then this is based on a little bit over 1,000 non-diabetic subjects. And the C-reactive protein levels show a stepwise increase as there are more metabolic disorders. And there's other data looking quite a lot like this by Ritker and so on. And high CRP levels also predict the development of type 2 diabetes. And here may be a case where CRP is actually more useful than it is for CHD. Now, we don't know how this, we could look at it by age, but we haven't actually done that. We probably should divide the distribution by, because the population is from 40 to 70, which is never really did that. Okay. Let's look at this. So I talked a little bit about the idea that pre-diabetics may have different patterns of metabolic disorders. So this is from the IRIS data. This is a paper we published in CERP in October. The subject here are pre-diabetic subjects who are insulin resistant but don't have a secretory defect. And this red group are people who are pre-diabetic but have a secretory defect and don't have insulin resistance. So we've taken the opposite parts of a 2x2 square. And these groups have the same glucose levels. You can see the only group that has high CRP levels relative to people who don't convert are the insulin resistant pre-diabetics. Now, is this really insulin resistance? Is it obesity? To do this, we divided the population by a median split by body mass index. When we did that, and this was sort of a surprise, is the insulin resistant pre-diabetics, whether they were leaner or fatter, had exactly the same CRPs, and they were high. The people with just a secretory defect had low CRPs, regardless of whether they were lean or fat. So the high levels of inflammation, which is a hot area, even in areas of dentistry, seems to be more related to insulin resistance than to obesity. And the reason why obese people have high CRPs is because they're insulin resistant, and not necessarily that they're obese per se.
But not in this case, though. I mean, it looks like obesity does have a...
But this group, the white group, is not constrained by insulin resistance.
Right.
When we did that, and it's actually in the paper, then in fact the levels are the same again. So obesity does have a role on CRP, but only when you don't take insulin resistance into account. So it's obesity making you insulin resistant, and that's the association with higher levels of it. So if you're obese but not insulin resistant, the idea is that you might not have high CRPs.
I'm sorry, I don't understand. It looks like the insulin resistance is separated out from the obesity in this
But isn't that just the high levels of resistance?
No,
high levels.
so the people who are
I see.
markedly
Sorry.
insulin resistant
I see.
have the same CRP levels, whether they're leaner or fatter. The Pi1 data wasn't so clean for this. I'm not showing you that. This was kind of interesting. So anyway, there are a variety of interventions. There's statins, there's lifestyle. Lifestyle is actually very effective. You get about a 25 to 30% reduction in CRPs. Metformin is not very effective.
When you say lifestyle, you mean weight loss?
Weight loss, basically. It's about a 7% weight loss. TZDs lower it. Skip on that. Let's talk a little bit. Okay. So, the NCEP sort of has a model, traditionally, that high LDLs were the major modifiable risk factor for heart disease. And in the 2001 recommendations, they came out with the concept that a metabolic syndrome leading to diabetes and also to CHD. So let's look at a little bit. And there's been a lot written about this that's controversial, and some of that is because data sets are different, and some of that's because people have different conceptual frameworks for what they're talking about. So the first thing, one view, is that environmental causes are responsible for the epidemic of the metabolic syndrome. And this is the kind of approach that the NCEP has taken. It's the approach that Dupre and Quebec has taken. It's visceral fat. And if you believe this is true, then what you would do is you'd reduce obesity and increase physical activity. A second conceptual framework, and we're going to come back to this when we talk about the World Health Organization definition, is that insulin resistance is the underlying cause of the metabolic syndrome. This is also the view of Jerry Reed. Obesity is fine if it's there, but it's really the insulin resistance. Now, if you believe this philosophy, then what you do is you could reduce obesity and increase physical activity, but you also might use insulin sensitizers, even in non-diabetic subjects. So this is a viewpoint most favored by pharmaceutical companies that make insulin sensitizers. It doesn't mean, by the way, this is wrong. In fact, several of these theories, they're not mutually exclusive. Another view is that inflammation is an underlying cause of the metabolic syndrome. And this even offers even more opportunities for interventions, because then you could also use things like statins, ACE inhibitors, and ARBs potentially. So these are different sorts of views, and people don't explicitly state this when they write papers, but these are the models that underlie them. So this is the NCEP definition. Now, in this definition, you have to have at least 3 out of 5 components. In this definition, no one is essential. So unlike the WHO definition, which requires insulin resistance, we'll get to that in a couple of minutes, and says you can have 2 of the 4 remaining factors. But if you don't have insulin resistance, according to the WHO, even though you have hypertension and a lipid disorder and you have fat and you have microalbuminuria, you can't have the metabolic syndrome. Okay, so what are these factors? So there's a waist circumference cut point, and it's 40 inches in men and it's 35 inches in women. Most people seem to agree that in some ethnic groups, the cut should be lower in Asian populations, particularly in South Asians. And the number you most often hear is 36 inches and 32 inches for men and women. Now, people ask about could you use BMI? And the answer is BMI and waist is highly correlated. The correlation's about 28. At about 28 is about 0.8 or 0.85. So it is statistically extremely tight. The cut points would be about 28 in the U.S. population. But waist really is pretty easy. You know, if you ask most women, they know what their waist circumference is. Probably have to add about 2 inches to it, but it's still pretty accurate. If you ask men, they claim they also know their waist circumference. It's always 34 inches. It's the last time they bought a belt for themselves. The belly just hangs out over it. So in women, it's pretty reliable. In men, it's sort of unpredictable. People ask about how do you measure it in really fat people? What do you do if, I know you never have people like this in the VA, where the belly hangs down and the waist is actually below their hips. And the answer is if their waist is below their hips, they have upper body obesity. And you don't really have to get a tape measure around it. So, I mean, this is not so difficult. The Iowa Women's Study had people self-report it. They measured in 100,000 women. They tested in about 1,500 people with it. And it really is pretty accurate. And it's true you should use a steel tape measure, but cloth tape measures don't stretch all that much. This is not so subtle. And most people claim that midway between the xiphoid process and the graded trochanter is the most accurate. Doesn't make any difference. We usually tell people to measure at the umbilicus because they can usually find it. If they can't find it, again, they have upper body obesity. So this really is not rocket science. Okay, what about the other features? Now, one of the things that's unusual about the NSAID is that they have separate criteria for triglycerides and low HDL. Now, why did they have separate criteria? Well, they had separate criteria because this was a lipid group. But it's a little peculiar. Most people, when they have criteria, they measure each dimension has a given thing. And this is going to lead to some funny data in blacks. Now note that the HDL cut point is different than the NSEP cut point. The NSEP cut point for major risk factors is less than 40 in men and women, where it's more liberal, that's a permissible word in Texas now, in women where the cut point is less than 50. So the blood pressure cut point, again, is lower than the JNC cut point, 7, or the NSEP cut point for a major risk factor. It's 130/85. How did they get there? Well, they got there because there was a paper published in the New England Journal from Framingham on high normal blood pressure, which looked at people between a systolic of 140 and 130 and a diastolic of 85 to 89, and found that it was associated with a major increased risk in heart disease. So that's where that number actually came from. And the last is a fasting glucose of 110 or higher. This came from the American Diabetes Association cut point for impaired fasting glucose. The ADA, in its infinite wisdom, lowered the fasting glucose cut point to 100 in November. And the NSEP has sort of footnoted this change when they came out with a report of an NIH conference in February in Circulation. Scott Grundy's the first author. So you probably should use 100, because that, I think, reflects where things are going. Okay, so what do you say? Well, the usual argument is about the metabolic syndrome is the average prevalence is 23 or 24%. That's a totally bullshit statement in a disease that differs by age. So the analogous thing in explaining to patients or residents is you tell them that the prevalence of otitis media in the United States is about 3%. But that doesn't say anything useful if you talk to parents of a 4-year-old whose kid is in preschool, where the prevalence of otitis is about 50%, meaning about 50% of the time. So what you really have to do is you have to look at the age-related data. In geriatrics, you know that. In the NHANES data, the prevalence more or less is your age minus 20. And it works reasonably well into the 60s. It kind of flattens out after that. And why does it flatten out? Well, this is prevalence data. There's a survival effect. So, you know, the people with the metabolic syndrome get removed from cohorts. But my guess is that if you looked at 70 and 80-year-olds, it'll be 40 to 45% overall. If you look at 90-year-olds, it actually drops. And there's some data, because these are people who are survivors. Okay? So I would think that for your group, 40% is probably a reasonable number until you get to the really elderly group. Okay. What about ethnic distributions? Well, it's highest in Hispanics, particularly Hispanic women. There does seem to be a deficit in African American men. Again, this is because African Americans, blacks, have low triglycerides and they have high HDLs. And since these are counted separately, they more than counterbalance out the increased hypertension and obesity and glucose intolerance. If you rewrite the NSEP criteria to make it high triglycerides and or low HDL, then African American men have the same rate of metabolic syndrome as Caucasian men, and African American women have a higher rate. So it's an idiosyncratic part of the definition. You know, you could imagine a scenario in which the American Society of Hypertension develops their own definition, and their definition is high triglyceride and or low HDL, and they have separate cut points for systolic and diastolic blood pressure. It's exactly sort of what the NSEP did, but it's stupid nevertheless. or the ADA can write it, and they have separate criteria for 2-hour glucose and fasting glucose. It's just dumb. Okay, so now let's talk about something which is actually important, and that's what's the magnitude of increased risk of the metabolic syndrome for cardiovascular disease. And I'm going to talk about 3 papers. The first paper, which is widely cited, one because it came out in a good journal and was earlier, and because drug companies like it because the risk is very high, is from a paper by a guy, Lacker. He's in Yuka Salinen's group. I don't know if anybody knows Yuka.
What did you say?
Yuka Salinen. He's the guy who claimed that iron was a risk factor for heart disease. You know, it's a journal of irreproducible results. He's had 50 papers in JAMA, and 48 of them have been refuted in later studies. It's really amazing. Actually, Lacker's not a bad guy. He just had a misfortune of working on this database. So anyway, this paper suggests that the relative risk of cardiovascular mortality is 3.5. Now, this is a big number. And to put it into perspective, let's go back in diabetes and CHD. So the Framingham data shows probably a hazard ratio of about 2 for diabetes and CHD. And for women, it's between 3 and 4. Now, this is data in men. So the claim here is that the metabolic syndrome might be more powerful than diabetes. And if you really believe this number, you probably would treat everybody with the metabolic syndrome as if they had CHD for risk factor management. Now, so are there any problems? What could have gone wrong? Well, one thing is chance, but that's not satisfying. You know, talking is an explanation for results you don't like. But there were only about 1,100 men, so there weren't a huge number of men. And if you look at the event rate in people without the metabolic syndrome, it's really very, very low. It's about 2% cardiovascular mortality over 10 years. So it might be part of this reason the hazard ratio is so high is because this number is so low. Normally we would have expected about 4%, and now would have made it about 70 to 100% increase risk. Now, I'm going to talk a little bit later about why it may actually be higher, because there's another interesting explanation for this. So, this is another paper. This is a paper based on prevalence data. So this is problematic as well. It's based on the N. Haynes population. So it's the same as Earl Ford's data, in which we describe the prevalence of the metabolic syndrome by age. And so in this paper, 85% of the diabetics had the metabolic syndrome. But if we focus on just this, people with the metabolic syndrome without diabetes had about a 60 or 70% excess risk relative to people without diabetes or with the metabolic syndrome. So if this number kind of gives you the right answer, then you would treat people with the metabolic syndrome is another major risk factor, like smoking or hypertension, where you might push them over the edge in terms of more aggressive therapy if they were just on the border, but you wouldn't automatically put them into the most aggressive policy. Now, it's very interesting, this new NSEP white paper that came out actually does sort of recognize the metabolic syndrome, and it was quite interesting. Okay, so we're going to talk about one more paper. This paper is going to come out in Circulation in September. It's based on data in the San Antonio Heart Study. Kelly Hunt, who's an assistant professor in our group, and it's a 12.7-year follow-up. And we're going to focus on just 2 of the populations. One is a group with no CVD at baseline, and the other group is with no CVD or diabetes at baseline. That's a true primary prevention population. Okay. So this compares the NSEP and WHO. And I'm going to focus on the
I
NSEP.
can't remember, how did you decide whether somebody had cardiovascular disease?
Okay, so this study is based on, it's cardiovascular mortality, so it's cardiovascular death encoding, which includes basically stroke and MI.
Yeah, but how did you determine there was no cardiovascular disease at baseline?
At baseline. That was based on an extended outcome of MI, stroke, or angina. There wasn't a lot of revascularization at baseline. We also included that.
So it was diagnosed?
Right.
Okay,
Yeah, we had no subclinical measures
okay.
of vascular disease. We do in some other populations. So here, it turns out that in this population, NSEP is better than WHO. But in other populations, WHO is better than NSEP. So there's a disagreement, but I'm not going to focus on WHO. So the metabolic syndrome is 2.7-fold. So it's pretty high with the metabolic syndrome. But this number includes people with diabetes. And remember, almost all diabetics have the metabolic syndrome, and people with diabetes have a high risk. So when you look at papers looking at the risk of the metabolic syndrome for heart disease, probably for clinical decisions you want to make, you want to restrict it to non-diabetics. And when we do that, you can see the hazard ratio falls to about 2. More like the concept of the metabolic syndrome being like a major risk factor. Now, note how much it falls in the WHO. It actually falls below unity. None of these numbers are statistically significant without CVD because the numbers get small in the event rates. So one of the reasons why WHO in some reports is very predictive is because it uses a glucose tolerance test. And a glucose tolerance test is a better way, a more sensitive way to pick up diabetes. Now, let's now carry this out further and let's look at it now in men and women. Most of you know that that when you look at the relationship between diabetes and CHD, there's a female preponderance. Women have relatively greater relative risk. Now, this again is looking at people without CVD at baseline, so this includes diabetics. But these numbers look kind of like the Framingham data, 3.9 in women, 1.8 in men. But we can ask ourselves the question is this greater risk in women with the metabolic syndrome due to the inclusion of diabetics? And the answer is sort of, but. So now we're looking at partitioning the data by diabetes and the metabolic syndrome. Now, this is the only paper that's actually ever looked at this by gender. So it turns out, and this is not rocket science, that people without diabetes and without the metabolic syndrome have the lowest risk of cardiovascular mortality, which probably is almost nobody at the VA. But they live forever. If you look at people with just the metabolic syndrome, it's about 2.1 in women, and it's about 2 in men. It's really not different. If we look at people with just diabetes, it's 3.5 in women, and it's 2.3 in men. So you start to see this female preponderance. And when you layer the metabolic syndrome on top of diabetes, then the risk really explodes in women. So both are important. The metabolic syndrome is important, even within diabetics, even though almost everybody has it, because the diabetics without it are somewhat protected. They're not completely protected. The risk isn't 1, it's not 2, but it's not far off. So in men, diabetes and the metabolic syndrome is sort of equally protective, and when you add them on, there's some increase in risk, but it's minor. In women, diabetes is more important than the metabolic syndrome, and there's a multiplicative effect.
So why do you think that?
Don't really know, and our data is kind of thin at this point. We could start to do some risk factor adjustment, but I think what you really need to do is you need replication of the basic observation before you spend. So this is sort of hypothesis generating. My guess is that what's going on is if you look at the differences between men and women with diabetes, one of the most striking differences is that there's a much bigger decrease in HDL cholesterol in diabetic women than in diabetic men. And we see that in pre-diabetics as well. Now, you can't tell that with the metabolic syndrome because they have different cuts in women and men. It's sort of arbitrary. But you can tell that in IGT subjects. The blood pressure in some studies is a bigger differential in women than men. The TG elevations appear to be similar. The CRP elevations appear to be similar. It's really not well understood. Now, some people have just explained it statistically, that when you add a risk factor to a low-risk subject, it always has a bigger effect. And since women are at much lower risk than men to begin with, then when you add something else, some of the effect is blunted. But we don't really know that. The other thing to remember, this thing about diabetes and CHD, although traditionally the Framingham data says that the absolute risks are the same, most studies in fact suggest that the risk of diabetes for CHD, absolute risk is actually higher in men than in women. So the Framingham, the abolishing the sex differential, isn't really true in about 90% of the studies. It's diminished but not actually eliminated. The other thing that's interesting is that there's a long medical literature on the effect of MIs. Now how does it go? The survival after an MI in women and men. And all of that data is based on coronary care unit survival. And the mortality is higher in women than men. But what that ignores is sudden death is higher in men than in women. So what we think actually happens is the rate may be the same or a little bit higher in men, but men get removed prior to hospitalization. It might be because of differential smoking rates. And in women, so they survive long enough to reach the coronary care unit, and then they're more at risk. Now, this needs to be written up well, because if it is, it suggests that secondary prevention strategies may be better in women than in men, and primary prevention strategies may be even more important in men. So there are actually, if this is actually true, there may be important implications, where men need defibrillators placed prophylactically, maybe less important. Okay. If we now take this apart and ask, we know the metabolic syndrome is a risk factor for heart disease. What within the metabolic syndrome is most important? And this is one study. This is the Alexander study. But it's not much different than many of the studies. It turns out that waist circumference and triglycerides are not so important. The things listed in red are significant, which are HDL cholesterol, blood pressure, and diabetes. Paired fasting glucose is not so important. So what does this mean? Well, if we think about who gets the metabolic syndrome in the United States, everybody with the metabolic syndrome is fat. And high waist circumferences are not such a strong independent risk factor. Doesn't mean it's not causal. If you look at what happens to what characterizes people in Europe with the metabolic syndrome, they all have hypertension. So what that means, and hypertension is always a strong risk factor for heart disease. So what that means is maybe the lack of data might be right. You might have different risks in a metabolic syndrome for heart disease based on where you come from, because they're different compositions of the metabolic syndrome, even with identical definitions. So one of the things you might do...
Is that why you get a multiplicative heightening of the risk by adding the two risk factors, diabetes and...
Yeah, except for the fact that that's mainly done in Mexican Americans, and they don't have such a high hypertension. We don't quite understand this, and it wouldn't explain the thing in women, but not in men. I mean, there are observations, and they so one of the things you might think about is that if you're thinking about intensifying therapy, and this is not in any recommendations, is that if they get the metabolic syndrome by just having impaired fasting glucose and a high triglyceride, but their HDL is okay and their blood pressure is okay, maybe they're not such a high risk for heart disease. On the other hand, if there's low HDL and there's hypertension in it, you may, and again, this is sort of breaking the simplicity of the metabolic syndrome apart, but they may not all be equal. So let's now talk about the other thing. This again is data from the San Antonio Heart Study. This is by Carlos Lorenzo. It came out in Diabetes Care in November. So we're looking at IGT versus the metabolic syndrome, and as everybody knows, IGT is a very strong risk factor for type 2 diabetes. If you look at it univariately, it's about a 4 to 6-fold increased risk. If you then classify people by the metabolic syndrome, it additionally contributes to risk. Among people who have normal glucose tolerance, the risk is about 4-fold higher, still pretty low. If you look at people with IGT, it's 2.5-fold higher, such that people in the San Antonio Heart Study who have the metabolic syndrome and have IGT, over 7 years, 55% of them develop type 2 diabetes. So this is a sort of group. If you might want to do lifestyle, but you might also want to give a drug. You know, if you have a 50+ chance of developing a disease in 7 years, it's pretty high. I wouldn't totally rule out a pharmacological approach to that as well. Now, if you then ask the question, are there some components within the metabolic syndrome that predict diabetes separately, then you get a different answer than you get for heart disease. Here it seems to be the obesity and the high glucose level which are strongest, and the HDL, blood pressure, and TGs are less important. TGs weren't significant at all. Okay. So, I'm going to go through this rapidly. I'm already talking to. This is the Onset metabolic syndrome. What you need to remember here is that this includes a measure of insulin resistance, and then it's any 2 to 4. This is not something you're going to do clinically because it involves glucose tolerance tests. You may have to measure insulin concentrations. It talks about microalbuminuria. It's much more common in Europe. If you ask the question about which is a better predictor of insulin resistance, Joey Reven had a paper in the Annals saying it wasn't very good. We actually had an earlier paper actually in diabetes. It isn't as good as WHO, but it's not designed to pick up insulin resistance. It was designed as something for heart disease. I mean, it's a misunderstanding of what these things have to do. I want to talk just, so anyway, how many of you seen this NSEP white paper that came out July 13th? And nobody saw it. So let me give you a 2-minute history of how it came about. We'll focus just on one thing. So the NSEP white paper came out a couple months before the heart protection study came out. The heart protection study suggested that in high-risk subjects, maybe people should be treated independently of their cholesterol levels. A lot of people actually do buy into this at this point. So they got working on the fact that they were going to eliminate this idea that you only gave statins if their LDL was 130 or above, to suggest that maybe everybody should get it, or maybe people just above 100. So they worked in the usual slow and deliberative way. And then they came out some data from a study that was published in April called Prove It. It was an acute coronary syndrome study that randomized people to Prava 40 and to over 80 and showed significantly less vascular events, 16% less. So they came up with a concept then. Well, no, traditionally the NSEP had 3 categories of risk. Very low risk, or low risk, which basically they said you might treat people pharmacologically if they're above 190 and the goal was less than 160. A moderate risk or moderately high risk group where the goal would be less than 130, and you would treat people either at 160 or at 130, depending upon the global risk, and their very high risk, in which the goal is less than 100, and you treat them pharmacologically at 130 or higher. So their initial intention was to wipe out the 100 to 130. But now with this data from the Prove It study, they introduced a concept of very high risk. And they suggest the LDL goal should be at least 70. And I technically think this is actually CVD in the report. I may have written that wrong rather than CHD. But, and at least one of the following conditions. So it's multiple risk factors, particularly diabetes, severe and controlled risk factors, especially the continued cigarette smoking. Multiple risk factors of metabolic, and for some reason they were focused just on lipids. I would have claimed that it should have been hypertension. You know, you could have made at least as good a case for hypertension or acute coronary syndrome. So the acute coronary syndrome seems to be justified because that's where the Prove It data was on. And maybe the diabetes data is justified because it's 2 to 3-fold higher. But the metabolic syndrome data, I think, is a little bit less clear, frankly. All of that data I showed you is in people who have not had a vascular event, and what you would predict is this 2-fold increased risk would be attenuated in people who did have a vascular event, after all. And then the current cigarette smoking, it's hard to argue with, I guess. So anyway, why don't I wrap up at this point?